I feel like that sounds like I do a lot, and I'm not sure. I'm in all of those areas always at the same time, but sometimes it sure feels like it. So thank you very much for the invitation today. I'm really looking forward to speaking with everybody and having some conversations. I did sort of just do a disclaimer when I joined the call that I'm in Alberta and our K-6 grades just went online for school this week. Both of my kids happen to be in K-6, so things are a little bit chaotic. So if anyone runs behind me in pajamas, I'll apologize in advance, but it's kind of the world we're in at the moment. Just before we get started, I will just let everybody know that I don't have any relationships with financial interest to disclose for this presentation. I have not received financial support other than the support of the invitation here, and there's no potential conflicts of interest to disclose for this talk today. Everything that I talk about, the material is peer reviewed and is used in academic settings, and there should be no conflicts of interest. I do also always aim to use inclusive and person first language, but as we all learn, if you ever catch me on anything, do feel free to just let me know so I can fix anything that may not be person first as we move forward. And then just before we get started, I'll tell you a little bit more about myself. But I know we're kind of gathering from, I believe, across the country. And I'm certainly certain that not everybody is in the same part that I am in, but I do want to acknowledge that although we're gathering virtually, that I'm currently part of this gathering on the traditional and present day territories of the people of Treaty 7 in southern Alberta. So this includes the Blackfoot Confederacy, which comprises the Siksika, the Piikani, and the Kainai First Nations, as well as the Tsuut'ina First Nation, the Stoney Nakoda, and that includes the Chiniki, Bearspaw, and Wesley First Nations. And I'm in Calgary, and the city of Calgary is also home to the Métis Nation of Alberta Region 3, which happens to be my nation. So welcome, although I am originally from a small Métis community in Manitoba, on the shores of Lake Manitoba. And this is just a picture of a medicine wheel in Nose Hill Park, which is a very large park we have in Northwest Calgary. And I am, as you heard, an assistant professor in family medicine. I've been working with people who live with dementia for a number of years, for almost 20 years, which seems a little bit unbelievable, I think, sometimes when I think about it, but it's been very, very rewarding. And I started out working with older people who were living with chronic conditions in the community, and started working with more people who lived with dementia. And then eventually started working with younger people because I could see the impact on family systems. And now I'm a member of the CCNA Team 18. And so I did my doctoral training in the United Kingdom. So my mom is Métis, my dad is a British immigrant who moved here in the 70s. And so I had the opportunity to just kind of go over there and experience a different healthcare system earlier. And that's where I did my PhD. So when I came back to Canada, I started integrating a lot of the work that I'd been doing into Indigenous health as well. The learning objectives, I'm going to tell you a little bit today around some of our current understanding of the drivers of dementia incidence and prevalence for Indigenous people, as well as describing a little bit of what we've learned, particularly around the urban experience of Indigenous people living with dementia. And then, we can start to think of some strategic thinking for improvements in services and supports for Indigenous people living with dementia, which is sort of the direction that my work is going. So I guess to start, and I know that it's sort of older people's mental health in general. So I think I'm focusing on dementia, but a lot of it, the way we talk about things is pretty transferable to other conditions. But I wanted to start out with just a very quick overview of looking at the experience of Indigenous people in dementia, what are the numbers like and all of those kinds of things. But there is data from Alberta, so that's where I am, around age standardized prevalence in dementia, but particularly in First Nations individuals. So it's actually 34% higher than non-First Nations individuals. And so maybe I'd quickly go over just in case, so we're all using the same words in the same way. When we talk about Indigenous people, that's our umbrella term for all of the First Peoples of Canada. So within Indigenous people, we have First Nations, which can First Nations people can be status or non-status, like treaty or not, or on reserve or off reserve. And then there's also Métis people and Inuit people. So the Inuit are in the far north, and Métis are the descendants of the first sort of voyageurs and First Nations people, and the homeland is in Manitoba. So when I say Indigenous, I'm meaning First Nations, Métis, or Inuit. And if I say First Nations, then I'm just meaning First Nations, just so that we're all using the same terminology in the same way. So the data from Alberta does show significant higher levels of dementia in First Nations individuals. Those prevalence statistics are consistent with other Indigenous groups as well. And then we can look at the data from other countries. So when we look, especially at early onset dementia, so it's sort of where I do a lot of my work, in Australia, in ages 45 to 64, so looking at those sort of working age adults, the Indigenous population sees 27.3 cases per 1,000 person years, and non-Indigenous population see 10.7 per 1,000 person years. And so what's interesting to me is when we look at the data from Canada, from Australia, from New Zealand, and from the United States, so these are all countries that have had similar experiences of colonization, we see these higher rates of dementia in Indigenous populations. And often when I have these conversations, people will say, well, especially for younger onset dementia, is it higher vascular dementia? Is it because of cardiovascular lifestyle factors? Is it because of reasons like that? And we actually don't see that play out in the data. So when we look, if we look at the Alberta data, the Alberta First Nations Information Governance Center publishes one-pagers on lots and lots and lots of different healthcare conditions, including a lot of chronic conditions. And when we look at the cardiovascular risk and we look at the cardiovascular conditions, we see a much elevated rate in Indigenous women when compared to non-Indigenous populations, but the higher rates of dementia are actually in Indigenous men. And so kind of, chalking it up to lifestyle or to cardiovascular risk doesn't actually tell us the whole story. But I think when we look across all these different countries that have similar experiences of colonization, which will include intergenerational trauma and adverse childhood experiences, then we see these trends. And so, we start to look at what are these cumulative effects of inequities. So we see the higher incidence and prevalence established, but what is the impact? And we're working on the drivers, what are those drivers? Is it colonization? What is the social context? And really the important thing is also to look at the impact of these inequities, right? So we see the inequities, we see health inequities at large for Indigenous populations being the result of colonization. And part of that will be things like different adverse childhood experiences, but some of it also is the way our structures are set up. So in Canada, we know that we have federal funding, we have federal non-insured health benefits that cover certain Indigenous people. So that's First Nations on the status First Nations people, and then everyone else is covered under their provincial healthcare plans. So we know that there's very distinct structures that treat people inequitably. We also know that it will compound, especially when we look at early onset dementia, a general lack of resources already present for younger people with dementia. So even in the work that I've done with non-Indigenous people who live with young onset dementia, generally that there's a lack of resources and services available. But planning these services and policies and structures and healthcare provision is really difficult without a full understanding of experience, particularly for Indigenous people. In order to improve services, and experiences in a culturally safe way, we need to develop our knowledge around lived experience and then access and barriers to health services. So I started some work. I had a student work with me for the last couple of years, particularly to look at the Truth and Reconciliation Commission of Canada call to action. I think it's number 20, just off the top of my head. So we know that the TRC, the calls to action, ask us and call to us to recognize that the current state of Indigenous health is a direct consequence of political and legislative policy, of residential school systems. But also one of the calls asks us to look at those differences for urban Indigenous populations or populations, Métis, Inuit, people who don't live on reserve. So we wanted to establish an evidence base, or begin to establish an evidence base around lived experience. We did some interviews with Indigenous people who were living with early onset dementia, or who had an experience with a friend or family member. So family, and all of my work with family systems, I've always defined family by the person who lives with dementia or a family member. They define family for themselves. So I am not going to dictate who counts as family and who doesn't. We also did interviews with healthcare providers, both Indigenous and non-Indigenous, who worked with younger Indigenous people living with dementia, and then did some thematic content analysis using qualitative description. So all of that largely to say that there was some very specific cultural considerations to look at when we look at early onset dementia. So there was a culture of community. There was Indigenous understandings of dementia in general, and I say early onset dementia, but largely the understandings of dementia in general were really, really important. And there was also a really strong theme around community connectedness and the impact on experiences of dementia services. So were there services in community? Did people have to come to cities to access services? And then, you know, especially I think with the case that was shared for today, when we think about people going to live in a long-term care, those facilities typically aren't near to Indigenous communities. So you'll have to think about some of the, in a trauma-informed way, of people being taken away from their communities to go live in an institutional like building, which could also be very re-traumatizing. So our key takeaways, I'm not going to spend a ton of time on the literature review and those things, but the key takeaways from that were that taking care of a person living with early onset dementia is seen as a duty or responsibility, but it's someone is beyond, their identity goes beyond just their diagnosis. And we hear this all the time for non-Indigenous people as well, that, you know, the need to be person-centered, and that person is someone with a lifetime of history and experience. They are a family member, and that care partners still experience the impact. So this contrasts with much of the literature around dementia caregiving for non-Indigenous populations, where we talk about caregiver burden. And that is often a focus of attention and service provision, but we're actually talking about the impact of the condition itself. And, you know, there was some really interesting feedback around someone not just being, it's not just the person that gets a diagnosis, it's a community. So that person is part of their community. As I mentioned, leaving one's community in order to live in an institution, so like long-term care or supported living, may trigger for some Indigenous people the trauma of being forcibly removed from their homes and families to go live in residential school. And then also when we look at layers of stigma, so we know stigma was named a top priority by people who live with dementia and care partners in the improving quality of life and care of persons living with dementia. The Academy of Health Sciences report that came out 2 years ago. So stigma was absolutely named a top priority. And then I think what's really important when we think about Indigenous experiences of living with dementia, to think of the additional layers of stigma. And I'll get to some quotes in just a second about that. So when we look at culture and ways of being, this was really important to people's experiences, resiliency and living with dementia, changes to family roles. And those aren't things that are hugely different when I talk to non-Indigenous people who live with young onset dementia. But then there was this Western versus traditional ways of understanding dementia. So it wasn't a departure from the person's identity. And rather, if we think of life in more of a cyclical mechanism, it's almost a return. So for some people were telling us they see it as a return to creator. It was a return to the way we started life, as opposed to a departure from the person I'd become, right? So less of a directional thinking and more of a cyclical thinking. Cultural context. So, you know, as I mentioned, thinking about somebody's role in the community, if that person is a knowledge keeper, if that person is a fire keeper, if they're a bundle holder, what is their role in the community, and how does then their diagnosis of dementia impact the community as a whole? Are they somebody who is really involved in helping out other families or providing meals and those kinds of things? And then that shared experience of historical trauma, of colonization. So moving from that experience to healing and wellness, what does this look like for healing and wellness? We know that we have the TRC, again, the calls to action, where we need not only more training in Indigenous health and caring for Indigenous people for our medical education, which is sort of part of where that medical education piece comes into the work that I do, but also we need more Indigenous healthcare professionals as well. So when we think about perceptions of healthcare services and experiences of systemic racism and stigma within the healthcare system, we have to think very carefully about the way we provide care. And we look at the ways of healing for Indigenous people living with dementia. There needs to be holistic supports for families, bridging support between urban and non-urban settings. So maybe people need a connection back to a home community if they have one, or maybe they don't have one and they want a connection to Indigenous healing or traditional healing alongside any Western healing, and can they access that in the city? And also trauma-informed care. We talk so much about personal and relationship-centered care and dementia, and it's very important. And alongside that, particularly for groups like Indigenous people, we need to think about trauma-informed care. So not necessarily knowing what the trauma is, but just being aware that there may be specific traumas that could be brought up through the way we provide care. And this was somebody who was a physician who works with Indigenous people who live with dementia. And they said, when I think about culturally appropriate services, they don't even exist in Alberta for Indigenous people with dementia. There's a huge gap. And then this was another person who has been working with, she's Indigenous herself, and she's been working with Indigenous communities and people who live with dementia for a long time. And she said another approach is to be inclusive and respected, and to be respective or have respect for Indigenous ways of knowing, being, and doing. There are ways of knowing, being, and doing that Indigenous communities and Indigenous peoples have been living for thousands and thousands of years, as opposed to enforcing one way and only one way that you're going to get better. And there is another person who took part, who happens to be a nurse, who does actually work with Indigenous people who live with dementia, and her sister was diagnosed with early onset Alzheimer's disease when she was in her 40s. And she said she always remembers they were on, I think they're just like on a little weekend break together, and her sister had gotten lost and they were in a strange city and ended up at the police station. And she said she was trying to tell them that her sister had dementia, and that they just assumed because she was First Nations that she was drunk, right? And they treated her really horrendously. And so that's what I'm talking about when I'm talking about those layers of stigma and also the racism that people will face in trying to live well with dementia. So then, just to wrap up, how do we put it all together? Well, we know our dementia strategy recognizes the diverse need and experiences of Indigenous communities, points out that there's a need for culturally appropriate and safe care and supports, that we need a distinctions-based approach. And so for anyone who's not familiar with that term, that just means that we need to recognize that there will be different needs for First Nations, Inuit, and Métis people. So we can't just, lump everyone together under Indigenous and have that be the same services and the same needs for everybody. Standardized cognitive testing is less accurate for Indigenous people, so there's possible misdiagnosis. I did see in the case that was circulated that the Kika is mentioned, so that's great. That's on my next slide, which is my last slide as well. And then also recognize the unique needs of people living with early onset dementia. So the importance of trauma-informed care, training Indigenous physicians, and Indigenous-led healing centers becomes really paramount. And then lastly, these are some of the directions for supports and research that I know, like I'm trying to work on, and many of my wonderful colleagues are trying to work on, but inclusion of Indigenous people living with dementia in developing education and in policy and care planning. The Kika, there's a team as all part of CCNA as well, but the U Calgary researchers working on it are looking at creating that urban adaptation. So there is the Kika that's been adapted. Manitoulin Island has the one, so that was in the case, right? So they've developed one, but it will differ based on community. So that's what we're talking about. So there's an urban version that's been a little bit delayed now because of COVID, but the work is doing that to adapt that for urban populations. Some work that I've been getting involved with is to look at therapy interventions, working with our health services here, and also some community partners to develop, a sensory intervention. One is using beaver pelt to see if that, almost like a sensory mat, right, that we can use that would be a bit more traditional. And then I'm hoping to start working on different types of reminiscence therapy. So when I was in the UK, I was on a team where we were developing reminiscence therapy for people who live with dementia. And obviously for older people living in dementia in the UK at the time, a lot of those reminiscence therapy interventions were like big band music and post-war things, which really wouldn't be appropriate for Indigenous populations here. So starting with the local populations that we work with, it'll be, one of the things that I'm hoping to start doing is to look at how do we have trauma-informed and really culturally led, culturally safe interventions for Indigenous people living with dementia, and be that, traditional crafts or hides or beadwork, what does that look like, and how can we take those reminiscence therapy tools to create things that are non-traumatizing and culturally safe. So a few things to think about. I hope that's useful for the case discussion. I'll stop sharing my screen.